Hi, this is Dr. Winbush with Sankofa Healing Arts and Functional Medicine. And in today's video, what I want to talk about or start to talk about is the answer to this question: is menopausal hormone therapy safe? So you'll notice that this is a part one. I anticipate that there's going to be at least a couple more videos where I start to unpack this really important question. And this is probably going to be the longest video because in this video, we are going to talk about what is really a very foundational study that was done, a women's health study looking at menopausal hormone therapy. And it is often referenced when you're reading anything about what do we know about the safety of menopausal hormone therapy. So I really want to take some time to go through this study to make sure that you have an understanding of it so that whatever you read that references the study, you really have that foundation. So this Women's Health Initiative study, the WHI, the goal of this study was to evaluate the safety of menopausal hormone therapy. This study was done quite some time ago. They actually started planning for it, I think, in the early 90s. The study was conducted in the mid to late 90s, and it was scheduled to finish in the early 2000s. But as we'll get to, it did not actually reach its planned duration of 8 years. And just to set the stage a little bit, there's been a fairly long history, at least in the 20th century. As modern medicine goes. So menopausal hormone therapy has been around in some form since at least the 60s. And I won't kind of go through all of the ins and outs of it, but by the time this study was being planned, menopausal hormone therapy was in pretty wide use. It was observed that it seemed to decrease the risk of developing heart disease in the people, the women who took it. And nonetheless, though, there had never really been a large study done. This was also around the time when people were really starting to recognize and the deficiency of medical research as it related to women and how underrepresented they were. And so this large study was planned to really answer this question: is menopausal hormone therapy safe? And the planned duration for the study was 8 years. However, the study actually ended up being discontinued before the planned end date, and we'll talk about that in a few moments. And this is a cover above the fold headline from the New York Times in July of 2002, when they are reporting about this discontinuation, at least of one part of the study. And then there was another part of the study that did continue for some additional time. But before we get to all of that, let's actually go through the basics of how this study was designed. So the Women's Health Initiative was a large study, and it was quite expensive. And for this reason, there's some people who say that we will never have another study, at least looking at menopausal hormone therapy, that was as large as the Women's Health Initiative. This study cost about $1 billion. So in this study, in the end, about 16,000 plus, it was a little more than 16,000 women between the ages of 50 and 79 were randomized, meaning they were sort of randomly assigned to one of two major treatment groups. One, which would be the menopausal hormone therapy, receiving hormone therapy, or not receiving therapy. And then within the hormone therapy group, there were a couple of subgroups. So one group received just estrogen only, and then the other group received combined hormone therapy with estrogen and progesterone. And what determined that was whether or not the person had had a hysterectomy, because we know that it's very important that someone who still has a uterus, meaning you've not had it removed, you've not had a hysterectomy, needs to receive combined therapy, because the progesterone, or as we're going to talk about, the people in the study did not actually receive progesterone. They received something that's somewhat similar. But we need that to protect against endometrial cancer. So just to recap, hopefully I did not make that overly complicated. 16,000 people randomized to two major treatment groups, or major groups, one who was going to receive hormone therapy and one who didn't. And then within the group that received hormone therapy, those who had still had their uterus received combined therapy. Those who didn't have a uterus received estrogen-only therapy. And it's at this point that I want to clarify that the hormones that were used in this study were not what we call bioidentical. And by bioidentical, that means that they have the same molecular chemical structure as hormones in our body. They are slightly different, synthetic, non bioidentical forms. And that does play a role in what we can say about the interpretation of this study. And we'll get to that in a few moments. So, the major outcomes that they wanted to look at in this Women's Health Initiative study were heart disease. It had been observed, as I said, that it seemed like taking menopausal hormone therapy, or HRT as it was called at the time, decreased the risk of developing heart disease in this menopausal period. So they wanted to look at that, and they also wanted to look at breast cancer rates and comparing sort of the risk or the rate of developing breast cancer in those people who received hormones versus those who did not. But they also had some other outcomes that they looked at, and some of those secondary outcomes you see listed here were stroke, blood clots, colon cancer rates, hip fracture, and then just what they call all-cause mortality or death. So this next slide is going to look kind of busy, but I don't want you to be anxious or become anxious. We're going to go through it, and really understanding this next slide is going to help you to really have that foundation to understand this whole study. So this is kind of a summary results slide. And what you see here is a table, and I'm going to walk us through this table. So in the column on what would be your far left are what we call the outcomes, right? And we just listed what those outcomes were that they were assessing in this study. And then we have the two major treatment groups, or the two treatment groups, I should say, the combined hormone, those people who received estrogen and progesterone. And even though we're calling it estrogen and progesterone, they're not bioidentical. And then we have the estrogen only group. And then what we're going to see in each of the cells is what was the effect or the risk compared to those people who did not receive hormone. So let's just go through it. I think I have, yep. So for heart disease, what we know is that in the combined estrogen and progesterone group, there was an increased risk of developing heart disease. And I've color coded this for us to keep it easy. So when there was increased risk, that's coded in red. In gray, it just means that whatever the estimate was did not reach statistical significance. And so these were kind of close to zero or a minimally elevated or decreased risk. So for heart disease, as it relates to the estrogen only, they couldn't quite make a determination, although it seemed like the estrogen only group had a slightly decreased risk. For breast cancer, we see that there was an increased risk of developing breast cancer in the combined treatment group, but actually, and we'll see it in green, a decreased risk in the estrogen only group. We see with stroke that consistently in both groups there was an increased risk. We see with blood clot, there was also an increased risk, although the size or magnitude of that risk seemed to be somewhat larger in the combined treatment group. And then we see a fairly consistent picture of decreased risk of both hip fractures and colon cancer, with a little bit of uncertainty about the estimate for the estrogen only group. And so this slide really starts to paint the picture for what we could see with these results, which is that there were some significantly increased risks apart from, significantly increased risks in the combined hormone group, and actually a significant difference or a substantial difference, right, in both directions, whereas you had increased risk of breast cancer in the combined group and actually a decreased risk in the estrogen only group. But then actually a fair amount of consistency in the other findings with increased stroke, increased blood clot, decreased hip fractures, decreased colon cancer. And the only other thing that I want to point out for you about this slide is that for some of the estimates, you'll see that we actually have some numbers in parentheses. And this is actually just trying to give you a much more concrete picture of what this actually means on a population level, because it's hard to really know what something like a 10% increased risk or a 40% increased risk means, because it really is dependent, it's relative to how frequently a condition is encountered to the size of the population that's studied. Whereas when we have these types of numbers, like that there were 8 more cases of breast cancer per 10,000 people who were followed for a year, or that there were 5 or 6 fewer hip fractures in people in 10 out of 10,000 people who were followed for a year compared to non-treatment. So that's the other thing I don't think I said. What we're talking about in each of these areas is what is the increase or decreased risk compared to not receiving hormone therapy. Okay. And so now let's move to the summary. We should be able to understand this now, that menopausal hormone therapy, and this is a very important point, using oral, meaning that these were pills that the participants were given using oral, non-bioidentical, we've already talked about that, hormone therapy was associated with an increase in the risk of stroke in both treatment groups, right? Whether you received estrogen only or estrogen progesterone, there was an increased risk compared to not using hormones. There was also an increase in breast cancer risk in the combined treatment group, but not the one that was seen in the estrogen only arm. There was an increased risk of heart disease and blood clots as well in the combined treatment group, and possibly a decrease in heart disease risk in the estrogen only treatment group. And then we saw a pretty consistent picture of a decrease in hip fracture risk and a decrease in colon cancer risk in both the estrogen only and the combined treatment group. So that is the summary, but I would not fault you for kind of coming out of that saying, well, so what's the big deal? You know, sure, there were a few areas where it seemed like hormonal therapy had some benefits, but there were also quite a few risks. And especially in the estrogen plus progesterone group, which anybody who has a uterus is going to need to take that type of therapy. Why are we even talking about menopausal hormone therapy today as something that might be beneficial for people when there still seems to be those risks that we just talked about? And so that's why I want to talk to you about a little bit of what we know in terms of what's come after this Women's Health Initiative study. I should go back to clarify that when the study was stopped, it was stopped early or prematurely because they were monitoring the data as it was sort of coming out. And so they were looking at sort of just big brushstrokes of what was the data showing. And most studies will have what they have called stopping rules built in, that if there starts to be a significant separation in terms of the treatment groups, meaning that they're seeing a signal of increased risk, if that magnitude of risk reaches a certain point, they'll just stop the study. But what has happened since the decision was made to stop first the estrogen plus progesterone group, that study was stopped a couple of years early, and then the second arm, the estrogen only group, ended up being stopped about 6 months before the completion date, is that some other aspects that were not taken into account have emerged. It doesn't mean that the study shouldn't have been stopped, but the initial reporting and the result, which was that tens, hundreds of thousands, if not millions of people taking menopausal hormone therapy were sort of abruptly taken off. It was not made an option for many people who came in the decades following the report of the WHI. What we realize now is that there was really a misinterpretation of the magnitude and actually of just sort of the overall findings of what could be said about this study. So the first aspect of this that I want to talk about is the age differential. So without getting too into the details or the weeds, you noticed when I talked about who was included in this study, it was people between the ages of 50 and 79. So almost a 30-year spread in terms of age. And obviously, if people were enrolled in the study and were randomized to the treatment group, you might have a 78 or 79-year-old person starting hormone therapy, which is generally not what you're going to see in common practice. It wasn't in common practice then, and it's not in common practice now. Menopausal hormone therapy is generally initiated shortly after people enter menopause or even are perimenopausal to address symptoms. And that's the second issue, is that for reasons that I'm not actually clear on, they only enrolled people in this study who actually were having fairly minimal symptoms. So in many ways, this group of people, of women who were enrolled in this study, are not really very reflective of who we are seeing and treating using menopausal hormone therapy today. The other thing that emerged is that we did have this large age spread. And so when they went and looked at the group and sort of subdivided along age, what we saw was very different. That between the ages of 50 and 59, so generally within about 10 years of starting menopause, assuming that the average person starts menopause around 50, 52, they saw a very clear signal of decreased risk of breast cancer, decreased risk of heart disease, decreased risk of stroke and death. When we move that into the next decade and look at people between the ages of 60 and 69 who were enrolled in the study, we still see that there was a decreased risk of heart disease and breast cancer, although there was an increased risk of blood clots and strokes, but no overall change in mortality rates. And again, this is all in comparison to people who were not taking hormone. And then in that third decade, we started to see a lot more risk, increased risk of blood clots, stroke, and heart disease, increased risks of mortality, and increased breast cancer risk. And so this has really led to something which I'm not going to talk a lot about in this video, because this is really just trying to give you a grounding in the Women's Health Initiative, to what we call the timing hypothesis, which is that sort of the best risk profile for initiating hormones is generally within that first decade after menopause. But this is just one part of the story of why we can't sort of make the Women's Health Initiative the end all be all of what we know about hormones. So we know that the age makes a difference. And a lot of the clear signal about this data emerged because they did continue to follow these people. Even after the studies were stopped, they've continued to follow them. The other thing that has become clear, and again, this is not necessarily due to the data that we have directly from the Women's Health Initiative, but is that the form of hormone that you take matters. And form, there's two aspects of form, whether you're taking something orally or in another way, and specifically as it relates to estrogen. We know that when you take estrogen by mouth, orally, it has to go through our digestive system. It has to then go and be processed by the liver. And in that processing, there can be is often an increase in clotting factors, inflammatory markers, and things that will increase the risk of blood clots, increase the risk of strokes, or even heart attacks. And that's why we sometimes see those conditions in people, especially if they have a genetic predisposition, who are put on like birth control pills, which are generally a much higher dose than menopausal hormone therapy. The other aspect of form that's significant is what I've already sort of briefly touched on. Are these actually hormones that are biosimilar, bioidentical to the chemical structure of the hormones that were made in our body, or are they slightly altered? And you might think sometimes, looking at the chemical pictures of the bioidentical form and then what they're using in these compounds, they're very similar, but they're not the same. And those slight differences seem to actually really have very big clinical differences. And so we'll talk about this in a couple future videos that I anticipate making. But we have seen that the non-bioidentical forms, especially of progesterone, seem to be a big part of the accounting for the increase in breast cancer risk and cardiovascular disease risk, especially that we even saw in the Women's Health Initiative, with the combined treatment group having those increased risks, especially as it relates to cardiovascular disease and breast cancer. So in final answer, at least in this video, is menopausal hormone therapy safe? Well, it definitely is increasingly recognized that menopausal hormone therapy, not of the type that was actually studied and administered in the Women's Health Initiative, but when it is provided in a bioidentical form, when the estrogen provided is not in oral form, generally is a both a safe and effective approach to managing menopausal symptoms in a large group of people. Certainly, there are some cautions and some things that we can talk about in future videos. But what I wanted to make sure that we got across in this video was this firm foundation of understanding the Women's Health Initiative, that oral non-bioidentical forms of menopausal hormone therapy are associated with increased stroke, that the risks really vary by age, with younger women seeing the benefit with estrogen therapy, right? That's what we can see in this study, is that the clear winner in terms of risk in the Women's Health Initiative study was in the estrogen only arm, but part of that's because the other arm was probably using the synthetic progesterone. And that there's different risks with combination versus estrogen only therapy, right? So the more breast cancer, heart disease, blood clot in the combination arm, and that this issue of whether it's bioidentical and whether the estrogen is provided in an oral form really accounts for that. So this was a long video, but I hope it's really gives you an understanding of the context and the organization of the Women's Health Initiative. And then I will make some shorter videos to talk about some of these other follow-on issues that we've raised.